Good afternoon, everybody. It's time for our November updates. So just to let everybody know ahead of time, so since we have the holidays for Thanksgiving this month, we kind of combined board meetings. So we don't have a board meeting in November. We have a board meeting only in December, and so that'll actually happen on December 3rd. And so after that, before Christmas, we will get the update that kind of includes those 2 months from a performance related standpoint. So we'll talk about what are we going to talk about today. So here's our topics. Back to break even. We're still working on that. Want to give you an operational update, kind of some of the things that are happening around the organization. We'll also talk about the KPIs, those key performance indicators that we are continuing to measure, a community update, some successes to date, and then also recruitment. I do want to give you a little bit of a teaser related to next month. So we just had our mock survey. So we have our survey with CHIQ, which is our regulatory body that kind of makes us say that, hey, we're doing all the right things, and that it keeps our ability to be able to get paid from Medicare and Medicaid. Hospitals that are not certified with DNV, Joint Commission, CIHQ, if you don't have that, that would eliminate you from having the ability to get payments from Medicare and Medicaid, which is a big deal for us, obviously. So we had a mock survey that took place because we are preparing for us to get our survey from CIHQ in June of 26. And so we do have quite a few things that we get to work on together as a team. And so all doable things are going to have to pull together as a group. And I know we can do an excellent job with that. And so I'll kind of give you some overview of that when we actually do the video for December, just to give you kind of a heads up on what's coming down the pike. So back to break even and the profitability. So days cash on hand. Remember the things that I've been kind of reminding everybody. That first threshold for us on days cash on hand is 100 days. So once we are at 100 days, stay at 100 days and continue to climb and grow that, that is one of the big indicators that starts to really help repair our credit, where we actually, just like your personal credit, right? We have the ability, if our credit's high, we get lower interest rates. We have the ability to get loans, but it also impacts our ability to even partner with people. So some companies that we may want to partner with from a service standpoint, if they look at a potential partner, right, being us, and that partner has a low credit rating, that can sometimes mess those deals up and prevent us from having some key partnerships that we actually need to have in order for us to continue to expand care in our community. When we look at our September salaries, wages, and benefits, our savings was about $402,000. We had a reduced supply spend of about $90,000. And so for the month for us, it was $492,004. If everybody remembers, when we think about our balance of revenue compared to expenses, we had a mismatch of, we were missing that mark by about $500,000. This is the first month that we almost hit that. So we were $8,000 away from hitting our goal. So great work by everybody. So I wanted to just share that because that's quite exciting, and there's been a lot of effort by everybody across the organization. So on operational updates, rehab, I hope everybody has saw that we've redesigned the flow there. That nice new front for radiology looks so good. We're going to continue. You'll continue. The next things you're going to see kind of in that main lobby area is us pulling up that carpet. So all that carpet is going to be gone out the door, vamonos. And we're going to have nice tiled floors that we're going to be able to keep clean and shiny and just look pristine, and it'll represent us on how we want to be represented. We're going to do some more tweaking down in the lobby area because that's everybody's first impression. So I want to continue to improve that. We'll get some new furniture for seating out there because some of that stuff is a little bit rough. And then kind of the next tackle for us is going to be that public bathroom that's in the lobby area. We'll have to remodel that. So we'll have to kind of get that on the docket. And when that's starting to come down the pike, I'll let you know. The hospital based sleep lab, we did have a transition and that was closed. We spent a lot of time trying to get that built up, but unfortunately the physician that was covering that for us no longer has a certification in sleep medicine. And so that doesn't allow us to be able to bill for any of those services. We did try to see if there was a way for us to mitigate that with, a telesleep physician, and we really couldn't come up with a good solution. So we did close that service. I think where we end up heading in the future as that technology continues to improve from an at-home sleep study, I think that's where it's going anyhow, and we'll definitely want to make sure that we're connecting as that service line continues to potentially grow. If y'all remember about some of our issues we had in the OR, remember when we had the big flood? We've definitely gotten our experience and, how to be flexible and pivot. But one of the things that happened the day after our flood in the OR was our air conditioner went down. And when that air conditioner went down, we had a significant amount of hours that we were above the acceptable temperature for sterile supplies. So we ended up having to actually throw away about $250,000 worth of sterile supplies, so almost $250,000. So what we have done to mitigate that, we're working on replacing that HVAC system because they're very old, and so that is a process. But we actually put mini splits in that big central corridor where the sterile supplies are stored. That is our backup. And so now even if that HVAC went down, we would be able to maintain the temperature just with the mini splits. And so we have that double assurance, right, that we're not going to have to waste money like that again in the future. And so I'm actually quite happy about that because I think it builds redundancy for us and it puts us in a much better position in order for us to, as we start to build and fix things, right, we want to try to make it easier for us to be able to be successful and try to make it very hard, for problems and issues to try to kind of take us down. And so this is just one example of that. A snapshot on the KPI progress, and we're honestly making some good feedback and some good movement in this. So one of the biggest things is on our revenue cycle. And as we've kind of talked about that in the past, and I'll just do a little bit of a review. So kind of our AR days or accounts receivable. What that means is that when we send our bill out of the care that we've delivered to our patients, and it's the amount of time it takes for us to get paid for those bills. There's lots of pieces that are, it's not one simple thing. There's lots of pieces, parts, and many places across the organization. Documentation by physicians, getting charges in, documentation by our staff, revenue cycle, case management. There's a lot of things that help us get to where we can send the bill out quickly after discharge. But this really measures the time it takes for us after we send the bill to when we get paid. We were running in the 60s or 70s. Our new number is 33. Our goal was to be less than 45. And so we have hit that goal. That is huge for us. So think about your paycheck. And if you had to wait 60 days to get your paycheck, right? It's kind of the same thing. Now we only have to, now we're getting those checks or that reimbursement within 33 days, which is really, really good when you think about some of the payers like Medicare, Medicaid, and some of our commercial payers. The other area that I think is really good to mention is when we think about the front door of the organization, right, where patients are coming in, one of the biggest front doors is the emergency department. And so we want to make sure that there are certain key metrics that we need to look and be very conscious of and make sure that we continually make sure that we have those hitting our goal or below it. One of them is our door to triage, and the next one is door to provider. And so what statistically happens, and this is a national metric that's been measured for well over a decade, is that if those two metrics stay within goal and you can get them as low as you can, your LWATs are left without being seen or left without being treated. That goes down tremendously. And what we used to think a long time ago was, oh, those people that leave, those people didn't really need care. And then as we started to study that, that was not the case. Actually, you had a lot of very acute people that were just too sick to sit in the lobby for that long. And so they would end up leaving. We don't want to have that take place. It's not in the best interest of our patients. And plus, those are actual admissions that actually need to have our care on the inpatient side. And so we want to make sure that we're really conscious of that. The other thing is our swing beds. We're having some great feedback of us getting the message out. Some of the barrier has been for us to get actually wound care, because a lot of our referrals, a fair amount of them that have been referred to us from other locations, have been that they needed to have some intensive wound care, and we didn't have that specialist on board. We do now have that. They're going through the credentialing process. And so, by January at the latest, I think we'll have that wound care nurse practitioner fully on board, and we'll be able to receive those patients both in the hospital as well as on the swing bed side. So I think that's quite exciting when we think about the progress that we're making. On the community update, McKinley County, that health fair in Gallup, we had some really great participation. There was actually a really great turnout. That was back in September on the 27th. We had a Red Rock public safety event. That was on 9/30. And then we also had, there's across the state, there has been 4 different locations that they have actually tried to really capture across the state of New Mexico related to malpractice reform and that tort reform that needs to take place, and how that is actually impacting organizations, both from a physician recruitment as well as malpractice insurance. And so one of the 4 panels was actually in grants. And I was very, very honored to be able to speak at that. It was a great dialogue with a lot of community members, some of our representatives. We're going to continue to push that, right? When we think about what we need to do for our patients, part of that is we need providers here. And if our providers feel like they, can't provide care in New Mexico because they're so worried about, getting sued for every little thing, it prevents people from wanting to stay, and it also prevents people from wanting to come, right? And so there's many states across the U.S. that have tort reform where there are caps on that. We do not have caps in New Mexico on punitive damages. And so we are pushing very hard to get that in this next legislative session so we can hopefully make some progress in that space. Successes to date. One is our first case on time starts. We've hit our goal for the first time, so we're super excited about that. The ORs are back open. We've been busy. We grew, actually. We've been running about 140 to 150 surgeries. We did 180 this past month, so that is super exciting, right? We want to be able to grow our surgical services, and we want to be able to provide that care to the community and them not have to leave. We talked about the supply costs. They started at about $1,300 per patient admission, and we're down to $858. So there's some significant impact that we've been able to accomplish there. Our DNFC and our DNFB have been at goal for 4 months in a row. What that means is discharge not final coded and discharge not final billed. And so as we think about that 33 days that we were just talking about previously related to our AR days, that's the end process after we've sent the bill. What we want to be able to do is when the patient is discharged, right, we want to be able to get that packaged up and sent to those payers as fast as possible. And so with both of these metrics being under the goal, that is super, super good for us because it keeps that process nice and tight. Our readmission rates, so anybody that has been discharged that gets readmitted, and what counts is if that happens within 30 days of when their discharge date is, it goes against us because we should have the ability to have people have the right resources and support once they're discharged to not have to come back into the hospital within 30 days. So 4 months in a row we've been there. Lab turnaround times and some of our key lab results, we've been at goal for 4 months in a row. And then I already talked about the 97 days cash on hand. So let's talk about some opportunities for improvement. When we look at some of our denial areas and we are breaking this down, we get feedback from our payers, right? We want our clean claims to go in, we want them to be paid, and we of course don't want them to be denied. And so we do actually look at this every single month and we try to figure out how do we mitigate that. So for us, timely filing, provider contracts didn't match the claim or service. And so we will then take a look at how are we aligning those things? What does credentialing look like? And where are some of the areas that we can put processes in place that we can fix that? AR days came down, but we want to continue to drive those as low as we can get them. If we can get to 30, it's probably going to be best in class. So we only had 1 month at 33. So, one spot on the graph is not a trend, but we want to continue to drive that. Our charge lag days were above benchmark, and we know that we've got some opportunities for education. We've got workflows that have embedded things that put charges automatically on the patient's bill, and we haven't necessarily all trained to that. And so that's really going to be one of the areas that we know we need to give some more support from a clinical informaticist. And so we're recruiting to have more access for our team, and so we can actually kind of rebuild some of that stuff and re-educate all of us that need to know. Swing bed, our length of stay is 1.17. It was about 7 days before when we were evaluating patients that potentially could go into swing bed. Our overall length of stay in the acute care side needs to be at 4 days or less. So that was not helping us, right? Now we're at just over a day. So the case management team is doing a phenomenal job with that. Overall turnover went down to 19%. We're been 18 to 19. Our goal is 18. And so we are right on the cusp of that. And I think we're probably going to end up averaging out to 18 for the year. So we want to keep a tight rein. We want to make sure we hire the right people, and we want to make sure we help them be successful, and we want to make sure we retain them. Our bad debt for us, and so that means the debt that we cannot get paid, either from a patient themselves, so they're part of the deductible, or a payer that we can't overturn the denial. And so we're at 10%. Our goal needs to be 2. So we do have some great opportunity in that space. I think we're going to continue to chip away at that. It's not something, honestly, that you can do really quick. It takes a lot of diligence and a lot of time and a lot of focus. Clean claim rate, we had it at 26% and we're at 18.8. And so what we want is, we really want, so 18% of the clean claims were denied, right? And so that's what that means for us. And so we want to get that down to 10% or less. So we want to have 90%. I'd like to be at 95, but our first goal is 90% for us of all claims that go out, they're clean, and they do not get denied. And as those come back, so that 18.8%, we're looking at those to see what are the trends. And that's why I was talking about the denials as one of the first things from an opportunity. And then how do we need to react to that, right? How do we need to put a new process in place or do education, or how do we need to fix that? The tighter we can keep the clean claims, right, that continues to drive that accounts receivable down. Clinic no-show rate, 25% for us. We have a goal because kind of the national best in class is to be 5% or less. I think honestly in our area, if I can get to single digits, I'm going to be pretty excited about that. I think we do have some unique things that are in our area. There's probably a greater than normal transportation issues, right? When we think about people on the reservation or just kind of outside on the outskirts of Gallup that are real issues for us. We don't have a subway. We don't have tons of public transportation. And so it is limiting for some of our patients. And so we're going to continue to look at those things, and the things that we actually can impact, we're going to impact, and there will be some things that will be kind of out of our control. So next, we will kind of, for the final, is going to be recruitment. Exciting. We have got Dr. Shaw, who's going to be our first full-time cardiologist. He will be 2 weeks on and 2 weeks off. The goal is for him to start February 1st. So really pumped about that. We have not had a full-time cardiologist in here for years and years and years. We also have 2 telemedicine physicians that are also cardiologists. And so we will be starting those services and similarly and close to the same time frame at the beginning of 26. That is going to have a big impact for us. One, on the floor, because we'll be able to take cardiology patients, but it's going to have a big impact for admissions through the ED, as well as, of course, they're going to have full clinics as well. So we have another 2 physicians that are in the pipeline for our second part of the half. Dr. Shaw fills half of the FTE. The next one will fill the other half, and so that'll give us full coverage 30 days a week. So super excited about that. We also have an on-site visit that's going to happen in this month in November, which is Dr. Jandari, who is a pediatrician. We've had that recruitment to bring somebody in to add to, to support Dr. McLaren so we can cover a larger pediatric population. And I think he's going to be a great fit. So it'll be his on-site. We've done video interviews with him, but this will be his on-site. So hopefully, it'll feel like a fit to us and feel like a fit to him, and we'll be able to land him as well. So thank you for your attention. That's all I have for today. I hope you have a wonderful Thanksgiving holiday, and I appreciate and value every single thing that y'all do each and every day.